A me è uscito
Eh
un...
sì, che è in diretta allo streaming, giusto?
Sì,
Ok, sì, sì, così mi creo il codice di YouTube.
che faccio? Chat?
Perfetto. Sì, sì, puoi accettare tranquillamente e ti ripasso a fare. Ecco, ti ripasso l'organizzatore.
Perfetto.
Ti chiedo nel caso se mi tieni come coorganizzatore in caso di problemi, così almeno
Sono-
anch'io lo tengo su.
Ecco qui.
Qui si sta collegando la collega Giorgia.
Salve, buon pomeriggio.
Buonasera.
Cioè, se mentre continuano ad arrivare messaggi da tutte le parti, faccio. Niente, secondo me non si collegano molto in anticipo i nostri relatori, per cui probabilmente se vogliamo possiamo fare le prove della sigla, giusto per capire se funziona bene, così.
Mi dica
Dimmi
lei.
tu. Sì, sì, dai, fai pure, facciamole che così quando si collegano i
Perfetto.
relatori non abbiamo questo da testare.
Allora, un secondo che condivido lo schermo. Allora, ditemi voi.
Forse è un po' alto l'audio, Giorgio?
Sì, un po' alto.
Così?
Il nostro posto può
Meglio.
abbassare?
Secondo me così va bene.
Sì.
Vediamo adesso che parte la parte comunicata.
Good afternoon, everyone. On behalf of Motioli Health, CME provider of the event, welcome. This is 50 minutes on multiple myeloma and is the first of 3 webinars. At the end of the 3 webinars, the second and the third one will be held on November 16th and November 23th. You will receive by email our questionnaire and satisfaction survey. The training
Direi che
credits
va bene.
for this project are
Perfetto.
4.5.
Sì, sì, sì. E l'altra versione, quella no voce, te la ritrovi, è uguale ma solo senza questa parte parlata, e la mettiamo in chiusura dell'evento.
E adesso la carico subito.
Mhm.
Ciao Anna,
Ciao,
Ciao
come va?
Alessio.
ciao,
Ciao,
tutto
ciao
bene, tutto
Pietro.
bene? Tu?
Gli darò un supporto tecnico a Pietro oggi
Da
così.
casa, perché vedo delle chitarre sul fondo che non sono...
Esatto, sono a casa, sono a casa. Sono in Sicilia più che altro.
Ah,
Sono in,
allora...
in patria questi 5 giorni.
Non
Vabbè, ci sta,
male.
ci sta.
Esatto.
Ci sta tutto. Sicuramente il tempo è meglio che qua, come dire.
Invece no.
No? Non bellissimo oggi, neanche
No,
lì.
no, cioè io ho portato la pioggia, in pratica.
Ah,
C'è
come
stata
faccio io quando
l'alluvione a
vado giù a
Parma, io
casa
ho
mia,
portato
uguale.
l'alluvione da Parma in Sicilia, quindi direttamente...
La stessa cosa che capita a me, ogni volta vado giù mi odia la gente.
Esatto, come me, cioè mi stanno odiando per adesso. Hai portato la pioggia.
Ragazzi, siamo pur sempre a novembre, per cui dai, ci sta. Un
Esatto.
po'. Nubifragio no, un po' di pioggia, dai.
No,
Però nubifragio anche no.
no, il fatto che i miei genitori mi avevano detto che c'erano 32 gradi,
Tu eri già pronto per andarti a fare il
mi ero
bagno?
preparato psicologicamente perché i fine settimana mio padre scendeva in spiaggia pure,
Ah.
ancora, cioè addirittura.
E tu sei arrivato, eh?
Io sono arrivato così, 20 gradi, però è meglio così, non c'è stato quello sbalzo di temperatura da Parma.
Beh, vabbè, ma guarda, secondo me si sopportava. Per una volta lo potevi sopportare, secondo
Quello
me.
sì, quello sì. Per ora che tempo c'è? Sta piovendo.
Sì, c'è brutto, vedrai che pioverà ancora di più adesso andare verso sera, però
Eh,
dai, ce la gestiamo, oramai noi ci siamo abituati.
esatto, esatto.
Niente, il
Va-
webinar di oggi dovrebbe essere molto tranquilla, un'oretta, sono solo due relatori che se la contano fra di loro, come si suol dire.
Ah, ok, perfetto.
Ci saranno, non ho le loro slide, quindi conto sul fatto che siano bravi a mostrarle. Uno lo conosciamo, Mina è sgamatissimo, non è un problema. L'altro non lo so,
Ah,
non lo
non si
so,
sa. Ok.
non lo so, ma
Lo
presumo di sì.
scopriremo solo di me.
Chiedo a Giorgia supporto perché questo qua è straniero, parlerà in inglese, quindi Giorgia a te la parola nel caso.
Brava Giorgia, perché
Eh,
uno che parla inglese, cioè, ci deve essere per forza. Bene.
No,
ci
questo qua è
proviamo.
greco, a meno che voi non sappiate il greco, ecco,
Ah,
Mm.
il greco
Ma
sì.
in realtà è una cosa positiva perché come noi sicuramente e come gli spagnoli parlano male inglese di
Esatto,
solito, quindi
sì, sì,
capisci
sì,
tutto quello che dicono.
sì. Ecco, sicuramente si capirà meglio dell'americana che doveva esserci il 23 cos'è? Sì, il 23 novembre abbiamo una che doveva essere americana, poi è stata sostituita come un'italiana, ma quindi
Di solito è Claudio che dà supporto tecnico se c'è un
sull'inglese.
americano inglese, perché lui sa tutti
Mm.
i termini. Cioè, lo conosco l'inglese, lo so parlare un pochino, però il lato tecnico,
Si è più in
no.
difficoltà a volte.
Colloquiale, ok,
Eh,
però il lato
no.
tecnico ci affidiamo sempre a lui quando
Ah,
c'è.
comunque questi qua sono tutte persone che utilizzano abitualmente le piattaforme per il webinar, quindi secondo me oramai
Quindi,
proprio vanno in
esatto.
autonomia con me. Ma poi è molto, molto bravo Mina, giovane, sgamato anche lui, per cui lui sicuramente interverrà nel caso a
Ne sono
supporto.
rimasti pochissimi che ancora non lo sanno, non le sanno utilizzare queste piattaforme.
No, ma poi figurati i medici.
Esatto.
Abbiamo dovuto anticipare il webinar alle 4 proprio perché
Perché
Mina
lo
aveva un
sgamatissimo
altro
è troppo
webinar.
sgamato. Un
Eh?
po' troppo sgamato lo sgamatissimo.
Sì, lo sgamatissimo è
Deve
anche
avere
un po' troppo
8000
scamato
impegni.
in contemporanea, sì,
Eh,
esatto. Poi si è reso conto che il suo calendar si era settato, era stato una
eh,
volta ad Atene, si è settato su un altro orario, quindi se li hai trovati
ops.
sovrapposti, grandissimo. Va bene. Niente. Ok, dai, direi che noi le nostre cose le abbiamo viste, se intanto rimaniamo collegati, se intanto volete fare altro tranquillamente, finché non si collegano i nostri, magari manderò un messaggio a Mina,
Allora io ne
giusto?
approfitto per fare una chiamata, la
Vai, vai,
tipa aggiunta.
vai, vai.
E io stacco il microfono pure
Sì, sì,
allora.
sì, anch'io
Perfetto.
stacco il microfono così andiamo avanti.
Va bene, a dopo.
Ciao Roberto,
Ciao Anna,
buongiorno.
buongiorno, mi
Salve.
sentite bene?
Sì,
Benissimo.
assolutamente sì. Tu?
Perfetto. Sì, benissimo,
Ok,
grazie.
bene. Io ho rimandato la mail a Terpos con il suo link in modo tale che
Sì,
lui lo trovi facilmente. Io non ho il suo cellulare, quindi spero però aveva risposto a te l'altro
sì,
giorno, per cui insomma sono solo i 47. Diamogli un attimo di
sì.
tempo, dai. Diamogli un attimo di tempo. Abbiamo
Anna,
i nostri due supporti di assistenza tecnica già collegati,
Buongiorno.
però se tu vuoi fare una prova di condivisione delle slide, se hai qualcosa,
allora, qua mi
vedi
dice che
tu.
l'organizzatore ha disabilitato la condivisione dello schermo.
Ok,
Ok, ok. Pietro, ti chiedo di darmi un secondo organizzatore a me. Glielo faccio un secondo io. Ok. Allora, opzioni di condivisione. Ok, Roberto, adesso puoi provare a condividere e te lo farò fare.
Sì, infatti, yes, esatto. Vedete, giusto?
sì?
Perfetto. Boh, ho tolto la condivisione, tanto in realtà sarà Terpos a dover condividere le
Sì.
sue slide.
Ti faccio presente, Roberto, che esattamente come l'anno scorso per questi webinar ho preparato una sigla dove c'è un testo introduttivo dove si presenta il fatto che questo è un ECM, è il primo di 3 appuntamenti e che quindi alla termine del terzo appuntamento le persone partecipanti riceveranno una mail con le istruzioni per gli ECM, poi c'è anche l'indicazione che le persone sono invitate a porre domande attraverso le opzioni di Zoom. Ti chiedevo a
Quindi
livello
in chat,
organizzativo,
scusami.
allora le opzioni sono due, se tu vedi, sia la chat che l'opzione
Sì?
domanda e risposta, per
Ah,
cui
ok,
vanno tenute e
perfetto.
monitorate entrambe. Ti spiego,
Sì,
l'opzione chat la vedono tutti.
sì,
Solitamente, mentre l'opzione domanda e risposta la vede solo noi lato, perché siamo i relatori del
sì,
webinar, e chi ha scritto la domanda. Gli
ok.
altri partecipanti non la vedono. Nel caso ti aiuto io a gestirle, quelle che arrivano su domanda e
No, va bene.
risposta, perché le possiamo anche eliminare progressivamente. Una volta che viene data risposta alla domanda da parte vostra, io te le elimino così progressivamente ti rimangono solo visibili quelle
Sì,
ancora da
ma
rispondere, ma è
sì,
tutto molto semplice, insomma. Immagino che tu lo sappia meglio di me. Invece, in apertura del webinar, tu
sì,
farai un'introduzione, una presentazione, presumo, giusto?
sì,
Io ho
io mi sono...
preparato una slide tappo molto semplice con il programma della giornata. Vuoi che la condividiamo o parli tu a braccio?
Allora, no, la puoi condividere.
Mhm.
In realtà, se volessi
Mhm.
condividere il programma, perché io
Sì,
pensavo di dire questo, ti sto di dire benvenuti alla seconda edizione del 50 Minutes On, che è un programma educativo, educazionale, io avrei detto organizzato da Mattioli col supporto di GSK, così
sì,
ringraziamo anche lo
perfetto.
sponsor. E avrei fatto un mini recap sui 3 episodi, quello di
Ok,
oggi, il prossimo e quello con le date e l'orario, quindi se si può
sì.
visualizzare quello, meglio. Poi introduco Terpos, spiego come funziona oggi, però tanto
Mhm.
quello alla gente non è che interessi sapere che fa la presentazione, poi la discussione. Dirò però che faremo una presentazione, che poi ci sarà una discussione e che ci sarà ampio spazio per le domande da porre in chat, eccetera.
Allora, lo vuoi condividere tu? Perché io ho preparato nella slide up c'era solo l'appuntamento di oggi, però tu giustamente dici introduciamo tutto il progetto. Se vuoi te lo rimando al volo tramite mail, lo condividi
Sì,
tu perché così
sì,
viene più semplice. Allora, ti
sì,
rimando al tutto tramite mail così te lo trovi
sì,
velocemente.
sì.
Ok. Io te l'ho inviato.
Aspetta che
Io un attimo che sì.
me ne è
È
arrivata un'altra
scaricato.
di me. Eccola qua. Allora. Lo metto qua.
In realtà dovrebbe essere la terza pagina, quella dove trovi il programma dettagliato con i 3 appuntamenti,
Sì,
perché c'è anche nella copertina, cioè nella prima pagina ci sono solo i titoli generali
sì.
e nel dettaglio invece poi della terza pagina trovi anche i relatori e gli orari
Io
corretti.
riesco a condividere il PDF, però
Sì,
cioè, mi
sì, puoi
viene...
condividere qualsiasi... Se provi a fare un check
Sì.
direttamente adesso.
Allora, condividi. Ok,
Esatto.
sì, si vede questo, va bene.
Si vede assolutamente quello, sì, direi di sì.
Va bene,
Perfetto.
quindi io dico organizzato da Mattioli, ovviamente qua suona il telefono, no, speriamo. Allora, aspettiamolo un attimo. Male. Ok. Quindi, ma com'è possibile che suoni ancora staccato? Ma- Ok. Quindi io dirò organizzato da Mattioli e
Con il
col
supporto
supporto di
di
GSK
GSK.
e basta. Quindi,
Io ho fatto un veloce check tra gli iscritti di GSK, non risulta nessuno, però loro hanno una pagina streaming separata in cui possono seguire il webinar, quindi se lo dici, insomma, a loro sicuramente
No,
fa
sì,
piacere.
sì, certo. No,
Poi
no,
ci sta,
certo.
insomma, noi l'abbiamo messo come logo alla fine della sigla, chiaramente, e
Certo.
niente di più.
No, no, vabbè, ci sta.
Mhm. Adesso dove sono? Tu ce l'hai il cellulare di Terpos?
No,
No? No,
Strano però che vediamo se ce l'aveva in firma, ma non credo.
no, secondo me non c'era.
Sì, c'è un mobile phone più 30 693.
Vuoi provare tu, Giorgia, a farmi un veloce squillo?
Arriva. Mm.
Non lo trovo. Ah, sì, in una delle primissime. Hello.
Hello, how are you?
Hello.
Just in
Fine.
time. Okay.
Hi, Evangros.
Hi, Roberto. How are you? Nice to
Good,
see
how
you.
are you?
I'm okay, thank you. I'm outside of the department because I'm giving a talk in a local meeting in Crete, which is
nice.
around 29 degrees outside.
Wow.
It's amazing. If you can see, everybody is in the beach.
We cannot see anyone, but that's better because we are a bit jealous.
Yeah, just a little bit.
Here is very gray, rainy, and certainly not 29 degrees.
So what is the temperature? Because I'm coming to Baveno on Saturday.
Let's say minimum 5-7 degrees, maximum
so it's winter.
15. Yeah, it's not nice.
So it's winter. Okay.
Yeah.
So you tell me how you want me to proceed. Am I going to start with the presentation? What is the plan?
First of all, if I can, I would like to ask you if you are able to share your slide, or we have to
I think it's better to share the slides.
Okay, but are you able to do it? Can you see
Yes.
the option on the menu?
Yes, I can do it.
Okay, perfect.
All right. Let me do it then.
Thank you.
Okay.
Sometimes we have to allow the participants to share, so
Okay. Do you see it?
Yeah,
Yes.
perfect.
And I'm going to the full screen. Right?
Ok.
Yeah,
Perfect.
perfect.
Okay.
So Evangelos, I will first I will introduce this program, which this is the first one of
Mhm.
3 webinars. So I will introduce myself. I will introduce the program. We'll thank the sponsors. I will just go through the three topics, and then I will introduce yourself. I will thank you for being here, and then you can start. I'll tell you. You can start your presentation
Yeah.
and share your slide. You can take, if you could take 30 minutes, that would be great.
Okay.
Then I have prepared some questions, practical questions for you about this, your topic. And then we will have some time for questions from the audience. You know that people are sometimes very shy, so we'll see
Yeah.
if we have questions or not, but whatever. I have many
Okay.
questions for you.
All right.
You know, the audience here is mainly probably young hematologists, so we'd like it to be as educational as possible.
Yeah.
And
This is
I
how
hope
I
you
have
can-
structured also the presentation. Yeah.
So we'll have some sun in Baveno, Sunday and Monday, but
Okay.
temperatures are not summertime.
No, it's
for
good
sure.
that I have to take a coat with me, probably.
Yeah. Oh, yeah. You should.
Yeah.
You definitely should.
I'll do it. Okay.
Can we stop the sharing of the slide now?
Okay.
If we are okay with the test, okay, so we are able to start with the webinar when it's time. Okay.
Ok, hanno un'informazione velocissima.
Sì?
Pietro deve condividere solo il video?
Solo il video, in quanto al termine della sigla passerà la parola a Roberto Mina, il quale poi farà una condivisione di quel programma che avevamo visto prima, e poi il professor Terpos inizierà la sua relazione e la sua condivisione. Quindi a vostro carico solo le sigle iniziali e finale.
Perfetto, va bene.
Ti rispondo anche in chat, visto che mi avevi scritto dopo.
Anna, scusami, un'ultima
Sì.
cosa. Come orario?
Sì, 16-17, quindi lo stop è per le 17.
Ok, va bene.
Ok?
Se abbiamo finito qualche minuto prima, noi possiamo lasciare la...
Se non abbiamo altre cose, sì, ecco, cerchiamo di portarci sull'ora per la questione degli ECM, sai, abbiamo questo vincolo, però direi che ci possiamo iniziare. Allora, sono le 16, per cui direi che siamo in perfetto orario e possiamo iniziare. Nel mentre do il benvenuto alla collega Silvia, visto che sei collegata in questo istante, ma è sul lato Mattioli, insomma, per cui se per voi è ok, we can start.
Evangelos, you're okay?
Yes, we can start.
Ok,
Yes.
allora a questo punto chiedo alla regia di lanciare il webinar e di partire con la sigla. Buon lavoro.
Buon lavoro.
Good afternoon, everyone. On behalf of Motioli Health, CME provider of the event, welcome. This is 50 Minutes on Multiple Myeloma and is the first of 3 webinars. At the end of the 3 webinars, the second and the third one will be held on November 16th and November 23th. You will receive by email our questionnaire and satisfaction survey. The training credits assigned to this project are 4.5. We would to point out that during the webinars, through the questions and answers tool, you will have the possibility to ask questions and the possibility to put a like on those that you consider most interesting in order to establish the priority of the answers. Thanks to all of you for your participation, to GSK for the unconditional support provided, and to Dr. Roberto Mina for the precious scientific direction of the entire project. Professor, now it's up to you. 50 minutes starts now. Good luck with it.
Good afternoon, everyone. My name is Roberto Mina, and I am an assistant professor of hematology at the University of Torino. And welcome to the second edition of 50 Minutes On, which is an educational project on multiple myeloma, focusing on BCMA targeting agents, their management, the management of side effects, treatment sequencing, and mechanisms of resistance, that is organized by Motioli with the support of GSK. And so before starting the first of the 3 webinars, I'd like to thank Motioli for the organization, particularly Anna Scotti for organizing everything. And so her precious help was fundamental to achieve and to organize everything. And I would also like to thank GSK for their kind support. So 50 Minutes On is an educational project aiming at dissecting all the available data on efficacy, safety, and the management of BCMA targeting agents, including ADC and T-cell redirecting therapy, including CAR T-cells and bispecific antibody. There will be 3 webinars. The first today with the presence of Professor Evangelos Terpos, and we will focus on the management of BCMA targeting agent, their safety profile, their administration, and the optimization of their use. Then on November 16th, there will be the second webinar, which I will host with the presence of Professor Sagalonial from the University of Emory, Atlanta, and we will discuss the treatment sequencing in the BCMA era and beyond. And then on November 23rd, Professor Niccolo Bolli will host the webinar, and we will have the presence of Professor Paola Neri from Calgary University in Canada, and they will discuss on their use of the mechanisms of resistance to BCMA targeting therapies. So we can start the first webinar. As I mentioned, we have here Professor Evangelos Terpos. Professor Evangelos Terpos is a professor of medicine at the School of Medicine of the National Kapodistrian University of Athens in Greece, and he's a worldwide renowned expert in multiple myeloma. We're very lucky to have him today, as he has a particular insight in BCMA targeting therapy. So Professor Terpos, thank you very much for being here. And before leading to you, the command, I would like to remind everyone that this is a very informal webinar. So we are lucky enough to have experts from all over the world. And so please ask any questions that comes to your mind. And we would like this webinar to be as interactive as possible. So Professor Terpos, thank you for being here today.
Thank you, Roberto. Thank you for giving me the opportunity to present, I think, this very interesting topic, and I hope there will be a lot of discussions at the end. I hope you see my screen. Now I'm going to put it in the full mode. Is it okay?
Yep, perfect.
So we are going to discuss today the management of adverse events, especially in patients who receive anti-BCMA targeting agents, and these are my disclosure. And as you all know, the BCMA targeted agents consist now of the 4th pillar for the treatment of relapsed refractory multiple myeloma after immunomodulatory agents, proteasome inhibitors, and anti-CD38 monoclonal antibodies. And they include especially the monoclonal antibodies with ADCs, like belantamab mafodotin, the two CAR-T products that have been licensed by EMA, Idacel and Cilta-cel, and two BiTEs that have been licensed by FDA, the one by EMA, also teclistamab and elranatamab, that is going to be approved also in Europe, and it has been approved for use in the United States. So we have 5 agents that we are going to see their efficacy in one slide for each one. So this is the belantamab mafodotin. This is the study, the DREAMM-2, that gave license to the product in 97 patients who received 2.5 milligram per kilogram of the drug every 3 weeks. You can see that in this population, all the patients were triplet-class refractory. The median duration of response was 12.5 months, although the median PFS was only 2.8 months, but for those who achieved the VGPR, it goes because of the median duration of response. The median PFS went up to 14 months and the median overall survival 15.3 months, compared to around 8 to 9 months in real-world data for triplet-class refractory patients. What are the problems with belantamab? Belantamab is a rather safe drug, but it has a special adverse event that happens due to the presence of BCMA in the cells of the eye. We have keratopathy in almost 70% of patients, and grade 3 or more in 30% of those patients. We are going to discuss that in details. Teclistamab, this is the trial that gave license also to this product. You can see in 165 patients, 77% were triplet-class refractory, 30% were penta-refractory. The overall response rate went up to 63% with a VGPR rate of 59%. Median time to response, 1.2 months. Median time to complete response, which observed in 45% of the patients, 4.6 months. 27% of the patients achieved an MRD negativity, and you can see that the median progression-free survival goes up to 11.3 months for those who has achieved a complete response, which is almost half of the patients, goes to 27 months. And the duration of response, as you can see, is 21.6 months for the overall population. What are the problems that we have for teclistamab? We have neutropenia. 65% of the patients will develop grade 3 to 4 neutropenia, but most important, this may lead to infections of, as you can see here, grade 3 and 4, 45%. And this is because the patients develop CRS, have hypoglobulinemia, and neutropenia. So these 3 factors lead to this very high number of grade 3 and 4 infection with teclistamab. How about elranatamab? Do we have any differences compared to the other anti-BCMA bispecific? You can see that this is the study that gave license again to the product. 123 patients, 70% had received the transplant. Almost everybody were triplet-class refractory, 42% were penta-refractory. You see the results similar to those of teclistamab, 35% of complete response rate, 56% of at least VGPR, median time to first response 1.2 months, median time to complete response 6 months, median PFS seems to be around 16 to 17 months with a 15-month probability of progression-free at 51%, and duration of response at 15 months to be 71%. How about toxicity? And you can see here from the publication that Nizar Balis just published in Nature Medicine. You can see that we have CRS here with grade 1 and 2 in almost 86% of the patients, but no grade 3 and 4. If you can see what's happening with hypophosphatemia, this happens to 36% of the patients, and the infection rate, which is not included in this table of the paper, but is around, again, 40% of grade 3 and 4. So it's more or less what's happening with teclistamab. How about the CAR-T products? This is the IDESL study that again gave license to this product. We have 128 patients, triple-class refractory, 84% of them. You can see the response rate, the overall response rate goes up to 73%. And the median PFS is 9 months. This is not the most impressive result for a CAR-T product, but if we go to the next one, which is the cilta-cel, you can see that the majority of the patients here are triple-class refractory, 88%, 42% penta-refractory, but you can appreciate that the overall response rate goes up to almost 100%, with a median progression-free survival to be extremely impressive, and is around 33 months. And I think that the 27-month PFS rate, as you can see here from the publication, goes to 55%. So the median is around 32 to 33 months. And you can see that the overall survival at 3 years to be more than 60%. What we have about side effects, both IDESL and cilta-cel had CRS in 84 and 95% of the patients, and 5% have grade 3 and more. But I think that the most important is the neurotoxicity, that you can see that 18 and 22% in the two products respectively develop neurotoxicity, but grade 3 is going up to 12% with cilta-cel, and I think that this is very important. The infection rate of grade 3 is a little bit lower compared to the anti-BCMA T-cell engagers, elranatamab and teclistamab, but continues to be high with 20-22% with the two drugs. One important issue is that with cilta-cel, we have delayed neurotoxicity in 12% of the patients, 10% of grade 3 and more, but we don't have delayed neurotoxicity with IDESL, which is less effective compared to cilta-cel. So let's go and discuss these side effects, and we start with the ocular toxicity of belantamab mafodotin. What we know is that after 13 months of follow-up of these patients who participate in the DREAMM-2 study, where the patients received belantamab mafodotin at the dose of 2.5 milligram per kilogram every 3 weeks, you can see that 72% of the patients develop a keratopathy. 56% they may have symptoms that like blurred vision or dry eyes, or they have at least 2 lines of BCVA decline, best corrected visual acuity decline. And if this change goes to 20 out of 50 or worse, this happens in 18% of the patient, and this is something important. I'm going to see you what this means. And only 3% discontinue due to corneal adverse event. You can see here what it means to have 20 out of 200 visual acuity, or you have 20 out of 50, or it is 20 out of 20, as you can see here. So I think that this is a score that the ophthalmologist can evaluate the visual acuity of the patient. What are the major findings in patients who receive belantamab mafodotin? The major finding is the microcyst-like epithelial change in the corneal tissue, because these are bilateral diffuse lesions on the slit lamp microscopic images, as you can see here, and the lesions were small. And as I previously mentioned, they are located in the corneal epithelium, as you can see here. With high magnification, it's required to visualize these microcyst-like epithelial changes, and the use of retroillumination of the iris or indirect illumination can facilitate the visualization. There are, as you know, 5 layers of the cornea. These cellular layers regenerate, enabling repairing after trauma, typically without scarring. And the monofethyl auristatin F that is included in the belantamab mafodotin is known to cause ocular symptoms. The keratopathy is the most common adverse event reported with belamaf, and occurred in several patients without symptoms, but in other patients with symptoms. The problem with the MMAF is that in the corneal we have cells that express BCMA. So the proposed mechanism is that belantamab mafodotin is entering the cornea and become internalized by basal corneal epithelial cell, where it includes apoptosis of these cells, as you can see here. Some cells containing the drug that have not yet undergone apoptosis migrate near the visual axis and cause changes in vision. Over time, new epithelial cells are generated and replace belantamab mafodotin containing cells that they have undergone apoptosis, and that's why we have the repair of the lesions. So we have different categories in the eye examination. We have mild, moderate, and severe keratopathy. And what we've seen is that we have mild superficial keratopathy in the mild category, decline from baseline of 1 line of Snellen visual acuity. And when we have these changes, we continue treatment at the current dose. But if we had moderate superficial keratopathy or decline from baseline of 2 to 3 lines, and the Snellen visual acuity is not worsening than 20 out of 200, then we withhold treatment until improvement in examination findings and BCVA to mild severity or better, and then consider resuming the treatment at a reduced dose of 1.9 milligram per kilogram. When we have severe keratopathy that includes severe superficial keratopathy with corneal epithelial defects and decline from baseline of more than 3 lines in the best corrected visual acuity, then we have to withhold the treatment until improvement in examination findings and the best corrected visual acuity to mild severity or better. For worsening symptoms that are unresponsive to appropriate management, we have to consider discontinuation of the drug that, as I previously mentioned, happens only in 3% of the patients. So this is the post hoc analysis which examined the relationship between the corneal exam findings, the BCVA changes, and the patient reported ocular symptoms to understand if additional factors outside corneal exams could be used to guide dosing. We have ocular findings that were assessed and graded based on exam findings before each dose of the belantamab mafodotin, and we also check the concordance and discordance between the eye professional eye evaluation and also the ocular findings that the patients describe. Here is the questionnaire that we used in everyday visit of our patients. For example, have you experienced any of the following during the last week? Eyes that are sensitive to light, that feel gritty, painful or sore eyes, the blurred vision, poor vision, and you have problems with your eyes, limited you the performity of reading, driving at night, working on a computer, watching TV. And you can see that the patient can score if this has never happened, or it is some of the time, or half of the time, or most of the time, or a lot of the time. And then we have a score based on that. And the other important question is, have your eyes felt uncomfortable in any of the following situations during the last week, like windy conditions, places or areas with low humidity, areas that are air conditioned. So we have all this scoring. You can see that the subtotal can be from 1 to 5, then for the score, then for 6 to 9, 10 to 12, etc. So what we've seen here is you see the summary of concordance and discordance between the corneal examination, the BCVA changes. So what we have seen is that the majority of the patients that have grade 0 to 2 keratopathy, we had grade 0 to 1 best corrected visual acuity. So this is the best concordance that we can have. But you can see that we have 12% of the patients who have grade 3 to 4 keratopathy, but only grade 0 to 1 best corrected visual acuity. So in the 95 patients of the DREAM2 study who were treated with 2.5 milligram per kilogram every 3 weeks, minimal or no best corrected visual acuity changes were associated with grade 3 to 4 keratopathy in this 20.5% of eye evaluation. I think this is extremely important because this means that these patients have not had any important symptoms. On the other hand, only 7.5% of evaluations found grade 0 to 1 best corrected visual acuity changes plus no symptoms, and grade 3 to 4 keratopathy when patients reported ocular symptoms were also considered. So, severe keratopathy and diffuse microcyst-like epithelial changes were among the most frequent corneal exam findings in the FEW evaluation, with grade 3 to 4 keratopathy and grade 0 to 1 BCVA plus no symptoms, as you can see here in this 7.5% of the patients. So, what we need to know about keratopathy of grade more than 2 in these patients? First of all, the median time to onset of first occurrence is more than a month. The median duration of the event is around 3 months. We have 77% of the patients to recover, and the median time to resolution, as I previously mentioned, is around 3 months. The recovered as of last follow-up is in 50% of the patients. The clinical outcome with first prolonged dose delays more than 2 months. You can see that even if we have this delay, about half of the patients in the 2 cohorts of the DREAM2 study, because the study included also some patients who were received belantamab at a dose of 3.4 milligram per kilogram every 3 weeks, most patients continue to experience a clinical benefit during the delay, and some even deepened their response during the delay. Very few patients had progressive disease. So this means that these patients, although they stopped belantamab, they continue to respond, which is very good for the patients. What we have to do to prevent the eye toxicity, you have to use TR Natural 4 to 8 times per day continuously, no use of contact lenses, cooling mask 1 till 4 hours per day, especially 1 hour before the drug administration, and of course the ophthalmology examination before any drug administration. That all these are what the ophthalmologists have to check, and they'll tell you what are the problems of your patient. Just to show you what it means to have a visual acuity of 20 to 20, 20 to 50, or 20 to 200. So you can easily understand that up to 20 to 50, you can imagine that there are no problems in the everyday life, but proportion of assessment with BCVA worse than 20 to 50 in better seeing eyes was in less than 10% in each cohort of patients. So I think that this is extremely important. The BCVA, the best corrected visual acuity worse than 20 to 200, which means that you have problems in your vision, was less than 1%. So the time to resolution from the 20 to 50, from here to baseline, is, as you can see here, around 1.2 to 1.3 months. So we go to the other side effects, like the cytokine release syndrome that happens with either ide-cel, cilta-cel, the 2 CAR-Ts, or the T-cell engagers. First of all, the cytokine release syndrome is triggered by the activation of T cells that release cytokines and chemokines, and as you may understand, the bigger the tumor load, the higher the probability of having the cytokine release syndrome. That's why we believe that possibly when we give it earlier at the disease course, or after transplant, for example, or for these drugs, we may not have these side effects, at least at this 80 to 90% with the ide-cel or cilta-cel proportion. They typically found within the first week and develop within the first week, as you can see here. And the risk factor, as I previously mentioned, is the bulky disease, the comorbidities, and of course the sepsis. We have to suspect the cytokine release syndrome if we have at least one of the following: fever, hypotension, hypoxia below 90%, and evidence of organ toxicity. So this is what happened with the CAR-T infusion, and you can see the CRS to develop within the first week. You see the grading of the CRS when we have temperature more than 38% with hypotension not requiring vasopression is the CRS grade 2. If we have only fever, we have more than 38 degrees Celsius, we have grade 1. If the patient requires 1 vasopressor, if the patient has hypoxia, needing a high flow nasal face mask or non-rebreather or Venturi mask will have a CRS grade 3. And of course, if the patient requires multiple vasopression because of hypotension, or the patient needs CPAP, BiPAP, or intubation, has CRS grade 4. These are what you have seen in the Majestic 1 trial with teclistamab. You can see that, I remind you that the incidence is 70%, with almost all events to be grade 1 or 2. So we have 5% of grade 3 and more in the cilta-cel and ide-cel with the CAR-Ts, but it goes to 1 to 2% for teclistamab or elranatamab. The median time to CRS with teclistamab was 2 days with a range of 1 to 6 days. The median duration was 2 days with a range of 1 to 9 days, 1 till 9 days, and all patients with CRS events resolved without the need for discontinuation treatment. Predictors of CRS with teclistamab include the low serum BCMA levels that were associated with, of course, low CRS incidence, and lack of association between CRS and interleukin-6 may be confounded by the use of tocilizumab. Lower frequencies of CD4 positive T cells expressing PD-1 and TIM3 were associated with CRS occurrence, and higher frequencies of CD3 positive T cells were associated with, again, CRS occurrence. The cytokines levels were not clearly associated with the incidence or severity of CRS. And you can see in the Majestic trial how the CRS events over time. So initially, as you can see here, we have grade 1 in 29.7%, 14% of the patients during the first cycle. Then as we go to the second, third, you see here the cycle on day 1, cycle on day 15, 22. When we go to cycle 2, only 2.4%, and this is grade 1, and then we don't see anything regarding CRS in these 119 patients. The challenges that we have with the CRS is that we have to be sure that this is because the fever, for example, is because of CRS and is not because of infection. So the patient's characteristics and treatment history that supports the presence of CRS include timing of fever within the typical range for CRS following the use of the T-cell engagers, the high tumor burden, especially with CAR T-cell therapy, the intense fever, more than 39 degrees, the elevated ferritin and CRP, that of course may also indicate the hemophagocytic lymphohistiocytosis that can happen with, not commonly, but with the use of the CAR-Ts, and the elevated rise in cytokines associated with CRS like interferon gamma or interleukin-6. Infection should be excluded with blood and urine cultures and chest X-rays. However, the infection does not rule out concomitant CRS. So the main problem for me is to differentiate between CRS, especially if this happens after the 5th, 6th days of cilta-cel, for example. With the bites, we don't have such problem. And the differential diagnosis, of course, includes infection. So we have to differentiate between the two. And increase in cytokines, the hormone of CRS, is not routinely assessed in clinical practice, as we know, and reliable thresholds have not been established. On the other hand, a large percentage of patients with severe CRS fulfill criteria for sepsis or septic shock with elevated lactate levels and the need for vasopressors. Although this makes it extremely difficult to distinguish the CRS from sepsis, distinct cytokine profiles have been observed to enable the accurate differentiation between the two conditions accurately following the CAR T-cell therapy. However, I have to say that in the ordinary, in the clinical, in our everyday clinical practice, sometimes it's very difficult to differentiate between the delayed CRS and the infection or sepsis for the patients. You can see what is the practical recommendation for the CRS management with a grade 1 CRS. If no improvement within 3 days and the absence of other differential diagnosis, we have to consider tocilizumab IV at a dose of 8 milligram per kilogram. For grade 2, tocilizumab has to be given before the patient transfer to the ICU for grade 3 and 4. That will have definitely the grade 2 CRS to alert your ICU. And tocilizumab is given. If no improvement within 8 hours, we have to repeat tocilizumab. And if symptoms persist and there is no improvement after the repeat, we have to consider dexamethasone IV 10 milligram every 6 hours for 1 till 3 days. If we have grade 3 and 4 CRS, of course, we have added dexamethasone, and then if no improvement, we have to increase the dose of dexamethasone from 10 milligram every 6 hours to 20 milligram for 1 till 3 days. And if the patient needs to go to the ICU because of grade 4 CRS, methylprednisolone IV 1 gram per day for 3 days, and then 250 BID for 2 days, and then 60 milligram BID for 2 days. This is the recommendations that were published by Jakub Aga in Hematologica in 2020. These are also the guidelines of the European Myeloma Network that we published with Heinz Ludwig in Lancet Oncology this year, where you can see that for grade 3, as we previously mentioned, you have to consider tocilizumab if the fever persists for more than 3 days, and we have grade 1. If we have grade 2, we have, as we previously seen, the tocilizumab administration and the dexamethasone 10 milligram IV every 6 hours if hypotension persists after the anti-IL-6 therapy, which is the tocilizumab. We have high risk for severe cytokine release syndrome and worsening hypoxia. Of course, we need IV fluids, bolus 500 to 1 liter to maintain a blood pressure of more than 90 mm. And if we go to grade 3, then we have to consider the admission to ICU. And after, of course, use of tocilizumab, we can increase the dexamethasone to 20 milligram intravenously every 6 hours. And if the condition is unresponsive, we can add anakinra at the dose of 10 milligram per kilogram daily for 3 to 5 days. There is a proposal here for the use of anti-TNF antibodies as clinically appropriate. What we are doing in our clinical practice, we are using anakinra in these patients. And if we have grade 4 ICU outside of the tocilizumab, the high dose methylprednisolone that has to be given at the dose of 1 gram per day, we use also anakinra in this if the condition is unresponsive to these very high doses of steroids plus tocilizumab. The pre-medication that is given for the T-cell engagers like teclistamab should be initiated to reduce the CRS incidence. So the pre-medication should be administered 1 to 3 hours before each dose of teclistamab during the step-up dosing schedule to reduce the risk of CRS. And we use acetaminophen, 650 milligram to 1 gram per os or IV or equivalent. Diphenhydramine 50 milligram per os or IV or equivalent, and dexamethasone 16 milligram per os or IV. So these are the 3 drugs that we use as a pre-medication. And during the step-up doses, the infection must have resolved before initiating teclistamab stepped-up dosing schedule or administer the next teclistamab dose to avoid exacerbation CRS. And you can see how it is the step-up dosing. We start with teclistamab 0.06 milligram per kilogram. On day 3, we go to 0.3 milligram per kilogram, and then the standard dose, which is the 1.5 milligram per kilogram. And then we maintain this dose continuously once weekly until disease progression and acceptable toxicity. Of course, as I'm going to show you in the infections, when we have a very good response, we may give the drug every 2 weeks in order to reduce the infection rate. And this is a very interesting study that was published in March in Cancer by Dr. Martin from California, where you can see that the prophylactic tocilizumab doses with teclistamab reduced the incidence of CRS only to 26%. Of course, there were only 23 patients in this, but you can see that the prophylactic use of tocilizumab reduced dramatically the CRS from 72% to 26%. 72% was the MajesTEC-1 population. How about neurotoxicity that we see it especially with the CAR-Ts? We don't have neurotoxicity grade 3 and 4 with the BiTEs. So this the so-called ICANS, the immune effector cell-associated neurotoxicity syndrome, is triggered by the passive diffusion of the cytokines into the brain, trafficking of the CAR T cells into CNS, monocyte recruitment, and macrophage activation within the CNS, as you can see here. We have a biphasic onset early or after the CRS resolved, and you have to suspect it if we have diminished attention, language disturbance, this is very important, impaired handwriting, confusion, disorientation, agitation, aphasia, somnolence, tremors or seizures, because especially with cilta-cel, we have some symptoms that mimic in Parkinson, and motor weakness or incontinence. You see the grading of the ICANS. We have a grade 1, for example, for the depressed level of consciousness. If the patients awakens spontaneously, awakens to voices, grade 2, awakens only to tactile stimulus, grade 3. Of course, an arousal requires repetitive tactile stimuli to arouse, stupor or coma, grade 4. The patients with grade 3 and 4, they have to go to the ICU because we may have prolonged seizures, we may have status epilepticus, we may have paralysis, diffuse edema on the imaging, and the posturing papilledema or the triad of Cushing. And this was the one of the first publications suggesting from the Mount Sinai the neurocognitive and hypokinetic movement disorder with features of Parkinson with cilta-cel, and there is approximately 8 to 9% of patients that may develop these problems. High-dose steroids are recommended for moderate to severe cases, and there is no clinical consensus regarding treatment of patients who do not respond to high-dose steroids. Preemptive mitigations with tocilizumab and corticosteroids has been explored as an option for the treatment of ICANS also, and all drugs like tocilizumab, cetuximab, and anakinra have been used for ICANS. We don't have the best solution. However, the recommendation from the EMN suggests that for the grade 1, the management needs to include only observation. If the patient is agitated, then haloperidol or lorazepam can be given every 8 hours, and we can consider early dexamethasone in patients with grade 1, and especially if they have some MRI findings. For grade 2, we need to go for dexamethasone definitely, 10 milligram every 12 hours. If there's no improvement after 48 hours, we have to consider high dose dexamethasone like in CRS, and then to include anakinra or tocilizumab, especially if there is concomitant cytokine release syndrome. And for the grade 3, if we have no improvement with the dexamethasone, then we need to go for high-dose methylprednisone, like the CRS, 1 to 2 grams per day, plus anakinra. And definitely in all these cases, we need to have an MRI imaging, and we have to check the CSF pressure, and if increased, we have to use acetazolamide, mannitol, or hypertonic saline. And of course, in grade 4, we have all the previous use, but then we may consider alternative therapies, including even lymphodepletion with cyclophosphamide or other drugs, and mechanical ventilation, of course, in the ICU. I think that these are conditions that you need to have a common approach with the neurologist in your center, that they have to know about the ICANS. This is something new for them also, but it is very important if you are giving cilta-cel or ida-cel in your patients. And I'm going to finish with infection mitigation and management. This is a real problem with the anti-BCMA bites. In the Majestic study with teclistamab, 76% of the patients experienced infection. The most common infection type was the upper respiratory tract infection. Grade 3 to 4 occurred in 45% of the patients, so this is a big number. 18% had the COVID-19. and 16 deaths related to infections, 12 due to COVID-19, 3 to pneumonia, and 1 due to PLM. I think that all these are important. PLM is the progressive multifocal leukoencephalopathy. And 4 of these were considered to related to teclistamab. To me, probably all of them are related because we have a lot of important problems with teclistamab, with the hypoglobulinemia, the neutropenia, the use of tocilizumab. All of them may increase the risk of infections. What we can do for prophylaxis, to me, the administration of antiviral and antibiotic prophylaxis during the period of infection, this is extremely important. We have to regularly vaccine the patients with inactivated microbes. We have definitely, to my opinion, to give IVIGs or sub-Q IGs in your patients, not only if they have low IgG levels, but in general, because we have seen that this reduces the risk of infection. These are the IMWG recommendations for bacterial, fungal, and viral prophylaxis. I'm not going to go into details. This is by Nupur Raja in Lancet Hematology last year paper. I think that you have to take them into consideration. For example, for levofloxacin use once per day, that probably has to be given in patients with bites. You all know the infection diagnosis, how to do it, and the treatment with empirical broad-spectrum antibiotics should be initiated, especially in patients with febrile neutropenia. And of course, if we find which is the agent that is responsible for the infection, then we give the specific prophylaxis and treatment. These are the EMN recommendations for prevention and management of infection. I just want to mention that in patients with low IVIGs, you see it here, the intravenous immunoglobulin every 2 to 4 weeks is strongly recommended. And I think that this is extremely important because, as you are going to see, the hypoglobulinemia is extremely important for patients who receive bites. And the dosage schedule is 1.4 gram per kilogram that has to be administered either every 2 to 4 weeks. We give it every 4 weeks in our department. The recommendation is for patients who have low IgG level below 400 and with severe and recurrent infections. However, I believe that this has to be given in all patients. These are the same from EMN. Why? Because this study that was presented by Saad Usmani in ASCO this year showed that when you reduce this is with teclistamab, when you reduce teclistamab, instead of giving it every 1 week to every 2 weeks, because the patient has a partial or complete response, then you can see that the grade 3 infection rate goes dramatically down. And especially if you give IVIGs from the beginning to your patients compared to those who do not receive IVIGs, you can see that the grade 3 to 4 infection goes below 20% in those who receive IVIGs, like what you can see with the CAR-T products. While if you don't give them, then you can see that the infection rate goes up to 80%, so which is totally unacceptable. So for me, what I'm doing in my clinical practice, I give IVIG in all patients who receive anti-BCMA targeted bites. Other CAR-T T-cell engager adverse events include the cytopenia. I believe that the hematologists are very well known how to use, how to deal with cytopenia, so I don't go into details on that. And the macrophage activation-like syndrome, that anakinra is the best way to go on. I think this is my last slide. I would like to thank you for your attention, and I hope that I am on time in order to have some questions. Thank you so much.
Thank you, Evangelos. This was a very, very comprehensive tour through all the toxicities of BCMA targeting agents. So before we get any questions, I have a lot of questions. So in the sake of time, I'll try to keep the most practical questions. So let's start with belantamab, which was the first drug you touched. So when we look at the ocular toxicities overall with belantamab, we'll see that the majority of patients will develop some kind of toxicities. But then, as you've shown very nicely, so a minority of patients will have some visual impairment, which I think it's the toxicity that affects the most the quality of life. So first of all, how do you think in your practice the toxicity of belantamab impact quality of life and the adherence to treatment? In other words, how frequently do you have to reduce the dose of stop treatment according to that? And how do you manage patients that have no visual impairment, but you have from the ophthalmologist some sort of signal that there's some epithelial alteration? So do you keep going, or do you just stop and then wait for the epithelium to recover?
Okay. First of all, I think that what's happening with belantamab and a little bit panic that the hematologists have with this drug was created because of the reporting of the side effect, and I will tell you what I mean. So first of all, you may have patients who develop keratopathy, especially at the dose of 2.5 milligram every 3 weeks. I didn't go into details because I have not had the time. When you use belantamab, for example, in combination with other drugs, that we give it a dose of 1.4 or 1.9 milligram per kilogram every 8 weeks, that we use it in the first line, for example, or in the second line treatment with combination with lenalidomide and dexamethasone, or with pomalidomide and dexamethasone respectively, and we've seen less than 10% ocular toxicity of grade 2 or more, and less than 1% of grade 3 and more. So to my opinion, it is important the dose and the frequency, but definitely in the in the label that belantamab has in Europe, you have to use it at the 2.5 milligram per kilogram every 3 weeks, because it is given as monotherapy, and we talk about patients who are true class refractory. So I do believe that with this dose, you may see some patients, not a lot, around 10 to 15%, that may have some visual problems. The majority, you may see that the ophthalmologists say keratopathy grade 2 and the patient has nothing, or they have some itching in the eye that goes very well with natural tears and nothing else. But in this 10 to 12% of the patients, what we are doing is that we are delaying the next dose. And we've seen that even if you give the dose every 6 or every 8 weeks, then especially if they have responded to the first dose, the response continues to be there. For those patients who have keratopathy grade 2 but no symptoms at all, we continue, and the ophthalmologist will see the patients before the next dose. What I have to say here is that the majority develop symptoms after the second dose, and then we may delay the drug. Either we give it at the dose of 1.9 milligram instead of every 3 weeks to every 6 weeks or every 8 weeks, according to what the ophthalmology tell us after 1 month, for example. But what I meant that there was a panic about this side effect is that how you can report, because I wanted to know how I can report the side effects. You can report them either that how many patients have at least one event, but this is not enough. You need to know how many patients have another event after the resolution of the first event, because what we know from the data of the DREAM2 is, for example, that 77% or 70% of the patients will develop a keratopathy, for example. And then almost all of them have resolution, or 75–80% have resolution. And then we don't know how many of them will have a new event after the second dose or after the consecutive doses of belantamab. I can tell you that this number is extremely low. So if you put, for example, in the number of ophthalmology examinations, how many of them they are let's say, positive for keratopathy for each cycle, then you can see that after especially cycle 3, if you have reduced the dose and give it every 6 weeks, you may see almost no keratopathy. So I think there is a lot of ways how to present something in order not to create this panic, especially for a side effect that the hematologists don't know and they are afraid of giving it. I believe that you have not to afraid, especially for patients with 3-class refractory. And as the drug probably is going to be licensed with pomalidomide and dexamethasone in earlier lines, then you can see that the approval will be for 2.5 milligram given every 8 weeks, which has lower levels. But if the dose is given every 8 weeks, of course, initially, after the 2.5 milligram, you may have something, but because you have the 8 weeks, the 2 months period, then everything has been healed. With a lower dose, you have even less keratopathy.
So do you think when given in combination after potential event, we will be able then to keep those in the patient, even reducing, and that could be the key?
I'm for example, in my first line study with belantamab in combination with lenalidomide and dexamethasone with a dose of 1.9 milligram per kilogram given every 8 weeks plus the standard Lendex, no patient has discontinued because of eye toxicity. And I can tell you that the majority of the patients now receive the drug every 12 weeks and nobody has progressed. With Bela-RD now we are to 24 months. We had, yes, 6 deaths, 5 because of COVID. So even with belantamab, which is an anti-BCMA agent, you have to be a little bit cautious about the infection. So probably targeting BCMA with whatever drug you have, BiTEs, belantamab may create infection, so you have to be careful. So what we are doing also, we are giving IVIGs, especially if they have low serum levels, and then we have no infection at all. But regarding eye toxicity, with even if the vast majority, I think 70% of the patients receiving the drug every 12 weeks, nobody has progressed after 24 months. So we are very near to the Maya result.
So last question on belantamab, and then a couple very quick questions about bispecific. So this is a question from a dear colleague, Dr. Chetani. She asked if you have any experience in belantamab administration in patients with previous keratopathy, I assume for other reasons, or in patients with corneal transplant.
Okay, I had a patient with corneal transplant and we had no problems at all. I don't know why. Okay, it may be random. Okay, it was only one patient, but with patients with keratopathy, we try from the beginning. And this is a very good question, because what we did also in the first line study that we did is that we checked the patients from the ophthalmology point of view, and we've seen that all of them, it is a study in the elderly population. So all of them had at least one of the problems, the most frequent one was the cataract. But the majority had problems and eye problems. And this is something that we have to take into consideration. We have to try to solve these problems, but we haven't given the drug in a patient with keratopathy to date.
Okay. So very quick questions. Infections are an issue with bispecifics, we know. So IVIG prophylaxis, you stressed the importance of IVIG. We now have some data. So you believe that everyone should receive primary prophylaxis?
Okay. I don't have the strong data to support that, but this is what I'm doing to my patients, because I have seen some very terrible infections in my patients treated with BiTEs, even with especially targeting BCMA. And we have also seen, we collect the data that with the continuous administration of sub-Q IVIGs, because this is what we have in Greece. We have this product of Takeda. Okay, it's not, this is the company, so I don't want to make any, let's say, advertisement, but this is the sub-Q IVIGs that we have, which is easily available. And we give in all patients who receive teclistamab or elranatamab And also, to be honest, for those who have low IgG, we give them even if they receive belantamab. But for the 2 bites, we give them in all patients, irrespective of their IgG levels.
Would you recommend vaccination before starting, particularly bispecifics and maybe CAR-T, according to the data we have about the impact of anti-BCMA?
Yes, we are doing vaccination, but the standard vaccination. We don't do anything more than the guidelines. Whatever the recommendations are, for example, we give them for the new vaccine for the COVID-19. We give them the new vaccine for influenza. So this is what we are doing also in our patients.
One last question. What do you think about early use of TOSI or prophylactic TOSI? You know, the guidelines say grade 2 or grade 1, but for more than 3 days. And in our experience, we've been using TOSI early on. So if patient had a grade 1 fever that was persistent, but not for 3 days, way less, we just give TOSI to get rid of the CRS. And potentially we have this nice data on the reduction of the CRS. So those mainly grade 1. So what do you think about it?
You've seen the data. I believe that this will help us a lot. Especially when this happens, especially with the bites, that the CRS happens within the first 1 or 2 days, that the probability to have an infection is rather very low. And so I believe that the early use of TOSI, even the prophylactic use of TOSI, may be of importance for the patient, especially if you combine it with the IVIGs. I know that this increases the cost of the product, but this is the only way to go on, because we have lost several patients with infections that they are treated in the real world with teclistamab, and I believe that we need to do our best in order not to miss these patients.
And it could also be a potential way for the outpatient administration of bispecifics if you can reduce significantly the risk of CRS to some
Probably
extent.
With the use of both TOSI and IVIGs, we may be able to give them as an outpatient. Definitely,
which cost effective would be, on the other hand, could be good, because I mean, rather than keeping the patient for 10 days in the inpatient, the dose of TOSI,
which is a real problem. Real problem.
All right, I don't think there are other questions. I think we are right in time, and so I would like to thank you, of course, for your presentation and being here. That was very, very nice of you. And I would like to thank all the participants, and we'll see next November 16th with Professor Sagalonia. Thank you, Dr. Terpo.
Thank you, Roberto. Thank you so much. Thank you. See you.
Have a good afternoon. Bye-bye.
Bye.
Thank you.
Thank you.